Doctor, we are live now.
Very good evening, everybody. This is Glaucoma Society of India's live journal club meeting. Today we have presentation by Dr. Geethu Gopakumar. She is a senior resident fellow in Sankanetralaya, Chennai. She's going to talk to us about the validating and updating the awards trial, the 5-year study. And we have Dr. Bhaskaran Mani, again from Sankanetralaya, as a mentor, as well as he is going to talk to us about the odds ratio. We have 3 panelists today. Dr. Rajul Parikh from Mumbai, Palak's Eye Center. Then we have Dr. Sushma Tejwane, Medical Superintendent NN2, that is Narayanethralaya 2 from Bangalore. Then we have Dr. R. Sharmila from Madurai, Arvind Eye Hospital, a senior consultant. And on today, I would like to say that we are having our Glaucoma Society of India meeting the coming September 12th, 13th, and 14th. If any of you have not registered, please do register. The meeting is going to be really a wonderful one. All the faculties are ready now, actually. So the wet lab sessions are also ready. So please register for the website, wet lab, as well as for the conference. We'll have a wonderful conference. We are looking forward to receive you all over at Bhopal. So without much delay, we'll start the session. First, I would like to request Dr. Geethu Gopakumar to present her topic, the journal topic, today's journal topic. And then once she's completing her topic, then we'll go to Dr. Bhaskar. Over to you, Dr. Geethu. You can
Thank
share
you, sir.
your slides.
Thank you, sir. Thank you for the opportunity. So my slides are visible, right?
Yeah, we can hear you and we can see your slides as well.
Okay. Thank you, sir. Good evening, everyone. Today I'll be presenting a journal article titled Validating and Updating the Odds EGPS Model Predicting 5-Year Glaucoma Risk Among Ocular Hypertension Patients Using Electronic Records. This was published in Ophthalmology Glaucoma 2025 March-April edition by Wright et al. Introduction. As we know, the ocular hypertension is a major risk factor for glaucoma, and the development of a tool that can usefully predict the risk of developing glaucoma in patients with OHD has been identified as a key research priority. A risk calculator based on the odds EGPS studies is available, but it is not recommended in clinical guidelines. Few words about the EGPS study. Randomized, double-masked, placebo-controlled clinical trial, which was conducted across multiple European centers between 1997 to 2003, included 1,081 participants of 30 to 80 years of age, IOP between 20 to 29, normal visual fields, healthy optic nerve heads at baseline. And the participants were randomized to dorsolamet 2% twice daily, the treatment arm, and the placebo group. And they found that there was no statistically significant difference between the treatment versus placebo groups, although the treatment arm achieved greater IOP reduction. So coming to the objectives of this EMR validation study, it is to validate and update the odds EGPS model, the model A, for predicting the 5-year risk of conversion from ocular hypertension to glaucoma. And they have used the electronic medical records from a large cohort of patients from 10 hospitals in England. Coming to the methods, the inclusion criteria, they have included newly diagnosed ocular hypertension in one or both eyes as recorded in the EMR, and they define the hypertension as IOP more than or equal to 22 millimeters of mercury and less than or equal to 32 millimeters of mercury measured with Goldman applanation tonometer, normal optic nerve, normal visual field test, and no associated abnormalities on clinical examination like pseudoexfoliation and pigment dispersion. And the exclusion criteria included the eyes with clinically significant ocular comorbidities such as maculopathies, patients with glaucoma of any type in one eye at baseline. IOP more than 32 were excluded as glaucoma suspect to match the original odd study, and those who didn't have any visual field testing and those with unreliable visual field testing were excluded. Coming to the data extraction, the EMR data they have extracted from the 10 hospitals in England, which they have used the Medisoft platform as a common platform, And why the hospitals were selected is to provide sufficient statistical power for the test. And the study adhered to tenets of Declaration of Helsinki, and ethical approval has been obtained from each center. So the records for all patients with a diagnosis of ocular hypertension or glaucoma at any time point, they were batch extracted with the assistance of the software, and before extraction, all personal identifiers were removed. So this was the how they have extracted the data from a population of 1,38,461 from these 10 hospitals, and the duration they have taken was from November 1995 to January 2022. Finally, the analysis data set contained 9,030 individuals and 13,891 eyes. The ethnicity of the participants, the 62.5% were white British, and 28.3% the ethnicity was not stated, and Indians were only 0.7%. So coming to the statistical analysis part, the primary outcome was the conversion to glaucoma within 5 years, and they defined the conversion as 2 consecutive reliable abnormal visual field examination with GHT outside normal limit and or the need for glaucoma surgery. And how the patients were followed up, they followed from the first normal visual field test until the date of glaucoma conversion, or they censored the patients at 5 years after the first normal visual field test, or the visual acuity dropping below 680, or the diagnosis of an ocular copathology affecting visual field. Whichever was earliest, till that time period, they have followed up the patient. So these are the basic characteristics of participants which were included, and these are the parameters they have analyzed: the age, ethnicity, sex, intraocular pressure, vertical cup disc ratio, CCT, pattern standard deviation, family history, hypertension, diabetes, glaucoma treatment. These all were considered. And here we can see in central corneal thickness, pattern standard deviation, and vertical CDR values, there were some missing values. So these also were taken into account later. So coming to the validation of the odds EGPS model, Model A. So this model was applied to all 10 hospital datasets to calculate the predicted risk of developing glaucoma in 5 years. And this is the Model A equations which gives the predicted risk. The predicted risk is equal to 1 minus 0.92 exponential of PI. PI is the prognostic index of the predictive index. So you can see the equation, there are so many numerical values. So the 0.23, 0.0, these are the beta coefficients of the which was obtained from the multivariate logistic regression analysis of the basic odds EGPS studies. And the numerical values inside the bracket is the centering values, that is the mean values of respective variables used to center the data. So centering is obtained by subtracting the mean of a variable from each observation. And the model discrimination they have assessed using Harrell C index, and calibration was done using the calibration slope. So C index or concordance index is the probability that a randomly selected pair of patients are ordered correctly. Suppose in a pair of patients, if one patient is counted as the patient with the higher risk, and if the same patient is converted first, then that pair can be declared as correct or concordant pair. So C index is basically calculated as the ratio of concordant pairs to the total number of informative pairs. And calibration slopes measures how closely the predicted risk matches the observed risk. So the C index and calibration they were calculated for each hospital, and it was pooled across hospitals using random effect meta-analysis. And as we saw earlier, there was missing data. So to minimize the risk of bias due to missing data, the values were imputed using multiple imputation by chained equations. And both internal and external cross validation was done. They have developed the model using data from 9 hospitals and validated it on the 10th hospital. And this was repeated 10 times with C index and calibration slope, and they pooled the data by meta-analysis. So further model variants were also explored. Model C, it includes all additional predictors except ethnicity. And Model D, it uses the IOP of the worst side. Model E includes only patients with IOP less than or equal to 23. Model F includes only patients who has not received any IOP treatment at baseline. And Model G, it includes only patients who never received IOP treatment. And they have used the logistic regression analysis to model the association between those baseline variables and to assess the probability of receiving IOP lowering treatment at baseline. So coming to the results. Validation of the odds CGPS model. The proportion of patients converted to glaucoma during this follow-up period was 16.9%, and the range was 11.7% in hospital 9 to 20.7% in hospital 1. So the discriminant power of this odds EGPS model, model A, was found to be suboptimal since the pooled C index was 0.61 and the pooled calibration slope was of 0.45, which again indicates poor calibration among this population. So the characteristic of the participants, in those patients with glaucoma, they were 4 years older on average. They have a slightly higher pattern standard deviation, and they have a thinner CCT on average. All other predictors were similar. So this is a calibration plot with original coefficients by model A, hospital by hospital. So here we can see the x-axis is the predicted 5-year risk, and the y-axis is the observed 5-year risk. And population in one hospital is divided into quintiles. They have divided into 5 subgroups. So these dots represent the quintiles. So if the dots standing above the line, that means the observed risk is higher than the predicted risk. That means the model is underestimating the risk. And if the dot stands below the 45-degree diagonal line, that means the predicted risk is higher than the observed risk. That means the model is overestimating the risk. That's how we interpret the calibration slope. So here with model A, they got the calibration slope of 0.45, which indicates poor discrimination. And they have evaluated the complete cases also, but they didn't find any substantial differences in the model performance. Coming to the updation of the odds EGPS model. So the performance of overall re-estimated model, the model B, was found to be more than that of model A. The pooled C index of model B was 0.67 compared to 0.61 of model A, and it showed a good calibration with a pooled calibration slope of 0.96 versus 0.45 of model A. So this is the table showing the performance of model A by hospital wise, and here we can see the IOP hazard ratio of IOP and CCT is 1.09 and 2.04 for model A. And in case of model B, here it is 0.99 in case of IOP and 1.06 in case of CCT. So in model B, the IOP and low CCT, they have found that it was not associated with conversion risk in model B. And the age, vertical CDR, Panther standard deviation coefficients, that both those were similar in model A and B. And this is a table showing the external internal validation with the model B. So the small n is the number of patients converted to glaucoma, and the caps n is the total number of patients in hospital. So each row, it represents the performance when that hospital's data set was the test set, and they are the all other hospitals were the training set. So here also the pooled C index is coming as 0.67, and the pooled calibration slope came out to be 0.96. So indicates a good calibration with model B. So this is the revised equation from the model B, and revised coefficients also we can see. So the effect of varying predictors. So the model C, they found that the gender and family history not associated with conversion risk, and hypertension reduced risk of conversion with a hazard ratio of 0.81. Diabetes is associated with increased risk, and the model D, the same estimates when worse IOP was used. So coming to the influence of baseline variables on treatment. So the age and family history of glaucoma was not associated with treatment at baseline with a p-value of less than 0.05. They found that there was a positive association between IOP and the treatment probability with an odds ratio of 1.13. Thinner central corneal thickness, there is an increased probability of receiving treatment with an odds ratio of 1.39. Coming to the discussion part. So coming to the validation part of the model A. So the model A, it was applied to a large real world data set, but the discrimination was found to be poorer than in original trials. In coming to the calibration part, the model underestimated the risk except in highest risk quintile. And the poor performance likely could be due to the population and practice differences. The reasons of poor performance could be, we know the odds and EGPS are randomized control trials, and they have scheduled 6-monthly visit structured endpoints. In this study, the intervals were longer and more variable, which is more representative of the healthcare system than data collected from the RCTs. And the other difference was in the definition of glaucoma conversion. ODS EGPS used assessment of both optic disc deterioration and the visual field changes to indicate conversion. But this study used the glaucoma hemifield test, mainly the visual field test only, without investigators' confirmation. So the cumulative risk of conversion from ocular hypertension to glaucoma at 5 years, it was higher than the odds cohort, but similar to the risk reported in the original EGPS study. So this is just a table showing the 5-year conversion rates for odds, EGPS and this EMR validation study. So odds, the treatment group showed 4.4% risk of conversion in 5 years and placebo 9.5%. EGPS, it was 13.4% in the treatment side and 16.8% in the placebo. EMR validation study, actually they haven't separately given. It include overall conversion was around 16.9%. And the odds follow-up studies of 13 years and 20 years also showing long-term progression in the non-treatment group. So coming to the updated model B, so refitting the model, it improved the performance. As we said earlier, the C index was increased to 0.67, calibration slope was approximately 0.96. And this was comparable to the risk prediction tools in other fields also, like stroke score charts to Q stroke score. So coming to the predictive factor differences. So the IOP and CCT were found to be not associated with the conversion risk in model B. So there is a higher probability of receiving treatment at baseline with higher IOP and lower CCT. So this could have influenced the result. And the diabetes, there is an increased risk of conversion possibility due to visual field defects induced by diabetic retinopathy and proliferative retinopathy, diabetic macular edema that can also result in abnormal GHT triggering the conversion event. And the hypertension less likely to convert, they have said that it is attributable in a part to treatment of hypertension with oral beta blockers. So coming to the strength of the study, that is a large data set capturing substantial variability across 10 sites in patient demographics. It's a clinically based data, it contained missing measurements, but the model performance, it was largely unaffected. And in odds, endpoint committee determined glaucoma conversion accounting for the presence of ocular comorbidities including visual field defects. But in this study, such eyes were excluded at baseline and those that developed comorbidities during follow-up, they were censored. So conversion risk estimates mostly were independent of comorbidities. Coming to the limitations of this study is missing data and conversion was based solely on visual field and there was imaging data was unavailable. And in vertical cup disc ratio, there can be inter-observer variability and unable to explore the possible influence of comorbidities on glaucoma conversion risk. And if there is a delay between the baseline IOP and the first visual field in some patients, so baseline IOP may not represent the actual value at start of follow-up. Coming to the conclusion, the original odds EGPS model, Model A, showed poor performance when validated in a large English population, but refitting the model, Model B achieved modest improvements in performance. But caution should be used when applying it to populations that differ from those in the original odds EGPS studies. So the MARI protocol, so methods were fair. It's a retrospective cohort study, validation of an existing risk prediction model. Assignment was good, large sample size, inclusion, exclusion were clearly defined, and it attempted to account for potential confounders also. The assessment, the primary outcome was clearly defined, given clear and clinically relevant definition for conversion to glaucoma. Results, there was 16.9% conversion to glaucoma. Model A showed poor discriminative power and calibration. Updated model showed improvement. Interpretation was fair. The updated model improved its performance, but we have to be cautious when applying to populations different from original study. And since the study used EMR data, it can be incomplete or inconsistent, which is a potential limitation. So coming to extrapolation, the findings are likely generalizable to similar UK populations with ocular hypertension, but the updated model, it may not be universally applicable without further validation. Thank you, sir.
Thank you, Dr. Geethu, for your wonderful presentation. And thank you, Bhaskar, for helping us in her presentation.
Thank you.
Um, Bhaskar is today's mentor for this presentation. First, we'll hear from you, Bhaskar, and then we can have a small discussion over this. Over to you.
Yeah. I would like to thank Dr. Geethu for summarizing it wonderfully. It's a little difficult, study to really go through. But actually, if you look at it, it is a retrospective cohort study. They looked at large data set from EMR, looked at the similar variables like the OHTS study or the EGPS study, and they just wanted to see if they are concordant, similar. But their prediction model has to be tweaked finally. So this is something which we have to take in from our population if we are going to apply the OHTS. And I think we need to create our own models or tweaking also if we are going to apply it, which is going to be much more complex because we are going to have much more different ethnicities within our country. So this is something which I want to give as a take home message. And obviously we are trying to treat more of these OHT patients. That's what we are seeing from the study that we have seen. I would like to welcome comments from the others as well.
The panelist.
Yeah, so I think first thing I agree with Dr. Bhaskaran that Dr. Geethu has done a very good job with such a difficult study. Yes, and she has very well summarized the limitations, which I would say it's a large data. So we need to look at how we are going to extrapolate it. It's a large data, but there are a lot of potential of noise as well. Because when we are looking at, although everything is very well defined, but when we look at their definitions of OHT and the conversion, we have to take it with a little this thing because they have only considered GHT, change abnormal GHT on two occasions, and optic nerve data is not taken at all, which is again a very this thing because visual fields can be affected by other diseases also. So those things have to be kept in mind when we extrapolate, and maybe that's why the model is not that well fitting. And it's a very clear cut message that, from the article that you have to test it for your own population before you extrapolate it. But the basic things that are missing is the clear definitions of conversion and a lot of missing data. Variability in vertical CD ratio, variability in the visual field thing is something that keeps this study into, this thing. Despite of doing such a large study and having put so much of an effort, I think it would have been better if those objective data were included, and that could have given the better results. Rajul, over to you.
So I totally agree. The other thing, because it was a retrospective data collection, it is very clear that so many percentage of the patients data was missing. They didn't have CCT, they didn't have vertical coverage ratio. I think 40%, 45%. So it was a typical retrospective study with all the flaws. The only thing they try to do something different, but I personally believe that the only OATS model would have been much better because the European glaucoma prevention study had its own problem to start with. So to look any data from EGPS, I am very cautious because the study, I think if you look the original study, that IOP reduction difference between placebo and treatment was, they didn't find any difference. So any model you based on a study which itself failed to show the even IOP reduction benefit. So I never actually use EGPS data in any of calculation or any articles. If I use EGPS data, I don't think it makes much sense to me. Otherwise, they've tried to create a good model. But Bhaskar was saying that for Indian perspective, if you have to use from the making policy or something, we have to have our data because this study is not helpful from that point of view.
Rajal, what's your take home for our audience from your perspective?
So as and anything based model based on EGPS, I am very cautious because EGPS study had lots of problems. So OATS wanted to do a collaborative data collection because from the huge number. Otherwise, I think that OATS study design and the methodology was much better than EGPS to start with. So I would make model based on odds rather than combining odds and EGPS. If I have to do anything, any study on Indian population, I will use only odds model rather than odds and EGPS together. That is my personal opinion.
All right. Over to you, Samila.
Yeah, I also agree with all of the three panelists who beautifully covered a lot of things which I was having in my mind. So, first of all, I think Geethu did a great presentation. It was a complex paper. It had a lot of statistics, and there were a lot of supplementary figures and all that, which he had taken it and put it for better understanding. That is really commendable. Second thing, what I would say is such a large population, when you're studying on such a large population, particularly extracting data from EMR, a lot of authenticity is missed. There's a lot of missing data. So that is one thing which is definitely given as a limitation. Nevertheless, both the models, whatever models they have used, they've already clearly told that the conversion is slightly higher with the EGPS compared to that of the odds. And this particular paper, whatever they have used, the model is a combination of both. And they say that it is almost equivalent to what is reported in the EGPS. Having said that, again, there is a lot of ethnic differences. There are a lot of differences with the definitions. They've never considered the risk ratio as one of the factor to see for a progression. They've just included visual fields. So that is one thing which is definitely a weakness. And they've also not taken into consideration all of the other factors that could be possibly causing a deterioration in the visual fields, which is again considered as a limitation. For example, a diabetic retinopathy or patients who have already undergone a PRP, which shows a visual field change, or anything which is like a RP or something, all of that could be in the pool, which is definitely not seen. So solely we could not say that this is the rate of conversion and we can apply this model right away. So that is another thing. So there are a lot of weaknesses in the study, and plenty of things have been pointed out, and there are a lot of strengths as well. So, but the bigger question is, in real practice, what I would say is in real practice, let's leave about the odds, let's leave about the EGPS. If there is a patient who's coming to your room, and then the patient has an intraocular pressure of 32, the patient has normal optic disc, the patient has normal visual fields, considering that this patient is coming from a really far off place, would you like to start on treatment or not? So that is a bigger question that would come into all of our minds. Although we put up the odds or we put up one of the predictive tools, somewhere down the line, there is something which is individualized. So all of us take our own decisions based on whether we need to start on treatment or not to start on treatment. And we do not have, a dogmatic rule or something saying that let's see if there's a patient who presents with an intraocular pressure of more than 30. Yes, 30 is a big number, so I would just start off on treatment. Or in other words, like if there's something like 23 or 24, I wouldn't start on treatment. So this equation, this balance is somewhere that we'll have to decide depending upon our population, what are the risk factors that we commonly come across in our population, and looking at that individual, whether there was a family history, whether there was any other risk factor like a CCT, which was very, very thin, presence of pseudoexfoliation, all of these things come into pool. So all of these studies actually help us to decide to a certain extent, but I don't think that you can just use these tools to, you just predict and say that, yes, this doesn't show a risk, so I would not start on treatment, or yes, this shows a risk, so I would start on treatment. So I would strongly think that the clinical decision making, it's totally on the clinician taking into consideration a lot of factors before applying all of these predictive tools.
Thank you, Samila. It's wonderfully done. And just to move on, how many of you really feel if they have the fundus, do you think in ocular hypertension we can really see the progression in case even if we have the fundus? The panel. So if we have the OCT, probably that could have given us a little better thing than just looking at the visual fields alone. But do you think the fundus details, do you think we could have really assessed the progression?
I think the
Only
structural
details of photograph.
changes are, sorry. I think the
Yes, go
structural
ahead.
changes is something which is very important, and I think the OCT has to be definitely put in place. And we need to get the objective measurements in the OCT. We need to check the macular ganglion cell. We need to see the RNFL. So all of those parameters, and also what's more important is we need to keep looking at the patient with the same machine. So periodically, you just see the progression using the same machine. That's also something which we do not know. If they've used the same machine to see the progression. So all of these things also have to be kept in mind before you really say that there is a progression. And
So,
definitely early detection in these individuals who are totally labeled as normal optic disc. And during the progression, you might definitely have to have a documentation of OCT to see the objective change.
but Sharmila, just to say that we all have the OCT, but we know that the visual fields and optic nerve head photography has been more standard than the OCT because the machines, the softwares, everything has been kept on changing. The technology of the OCT, everything is kind of changing. But having said that, in this particular study, do you think they would have done that OCT possibly? It is quite difficult. That is one of the main reasons I would like to point out. Other panelists, others can also add in your inputs.
Such an optic disc images, I think, would make also along with the perimetry. But then optic disc photography also has other lots of other issues. So your exposure, if is different every time, it will give you, some artifacts and problem in the analysis. Of course, now
I
with the
completely agree. The only thing for me is
now,
both the OCT and
no,
the photography may not have given you in-depth detail because OCT, as the technology has changed over a period of time, it is quite difficult to see how much is the progression, one thing. And looking at the photography alone, looking
yeah.
for a
So if
progression,
you do now,
unless it
if
is
you
a
do
very obvious
if you do
change.
now using the AI, it may give little better.
No, that is okay, but we are talking about this in reality. The patients were there, they have done it. So in reality, I'm saying it could not have been possible other than looking at only the visual fields changes.
So Dr.
And very,
Nikhil,
very frankly, as Sharmila was talking about, eventually the role of models becomes only for making the policies. Otherwise, in day-to-day practice, when the patient is in front of you, there are so many other parameters also play a role, whether you are going to treat or not. So only making the models, and especially this model, we cannot use because of lots of limitation. But models is to make a broad guideline, not to treat day-to-day patient. That is my
actually, one of the points which I want to make here is whether it is US or whether it is NHS, they want certain models to tell the administration that they want to start the treatment in such patients, so that it is approved by the NHS for treatment. Otherwise, they
Correct.
won't get the
More of
money
a
to.
kind of a
Yeah.
standard, kind of a
So
practice
that is why
pattern.
these models are encouraged in such systems. But for
Yeah.
a given patient, I would say that if you have both the red-free disc photography or the continue multiple disc photographies over a period of time, or if you have an OCT which is properly done over time, will make a difference in coming to a conclusion whether to treat the patient or not. So
Yeah.
that is definitely there. I hope that probably the OHTS studies which are being done can follow up with the OCT progression with the newer softwares and see whether that makes a difference also. That will give us some guidelines as well, because it's a bit dicey, because many a times the artifacts are there and people are treating only with OCT. So at least some guidelines will help us to make some decisions.
So the
That's what.
fundus photography in line with the OCT and kind of visual fields together, all together, then possibly it might give us some idea that whether we would like to go with a further treatment or just observation. Bhaskar, can you just
I will try to share.
conclude on this topic so that there is
Yeah.
some message for our audience?
Yeah, so basically this article was presented for two reasons. One is the accompanying statistical topic, odds ratio. This is a retrospective cohort study and there are lots of odds ratios that are coming in. So for you to understand the topic, one thing. Second thing is, of course, we are all interested in conversion to glaucoma. So these are all models which are there, but then using the model has restrictions. and in our population, that is one of the other reasons. And of course, from a journal article perspective, you can see that it is a big data, and then they are using multiple models. Irrespective of that, it is not giving good results compared to the original model, that is the OATS and EGPS. So one need to be very careful when you are dealing with retrospective data. So this is the take home message from the perspective of a journal article, as well as the statistics, as well as OHT conversions. So that is what I wanted to conclude with.
Thank you, Bhaskar. Thank you so much, and thanks all the panelists for your wonderful inputs for this particular topic. Next, we'll have Dr. Bhaskar's topic on odds ratio. As Bhaskar had some difficulty in the slide share, request Manjula to share the slides so that Bhaskar can start his presentation.
Yeah, thanks a lot. So the topic for today is odds ratio. While Ms. Manjula is sharing the screen for this topic, I'll start off with this. So what you saw in the the tables, and many a times Dr. Geethu was talking about odds ratios. So basically, we are looking at an exposure, giving the disease, or the amount of exposure that is present in a particular disease. So what is the difference between these two is what we are going to look at in the beginning, and then to see what kind of measurements can tell us these associations. So that is about the odds ratio and how we are using it in the practical sense that we are going to see. Ms. Manjula, can we have the slides? I have sent you your email ID.
Yes, doctor. 1 second, doctor.
So odds ratio is what we call as a it's effect size. That is the measurement in research methodology that we use. Effect size literally means that how much is the association between the exposure and the outcome in a case control study or a retrospective cohort study. So I hope the screen is visible. Can I have the full screen? Yes. Sorry, I have to bother you going to the next one. So next. So we have these events when we are dealing with disease or blindness or any kind of complication, that is the outcome. And then the exposures, which are possibly the clinical characteristics that we are looking at, or genetic predisposition. If you're talking about the case control study, one of the classic examples that we deal with nowadays is the genetic risk factors. So if you have a mutation, what is the risk for developing the disease is usually described in odds ratio. So that is one of the exposures. Of course, intraocular pressure is an exposure and glaucoma is an outcome. So we are going to look at the association between the two. These are all the various epidemiological events which come as exposure and the outcomes. Next. So we have to have a measurement to describe it quantitatively so that we can know the amount of exposure, that is the association between the exposure and the outcome in various designs of the study. For example, if it is a case control study, it is a retrospective study, we have the odds ratio. And then if we have the cohort study, prospective cohort study, we have risk ratios. We will come to that. So you are seeing here an events occurrence, that is the exposure and the outcome. And you have the association between the exposure and the outcome. We have rates and then the effect measures. Let us see what are the rates next. So when you're talking about prevalence rate in a cross-sectional study, we are looking at so many glaucoma per 100 population above 40 years of age. That is a prevalence rate. And we are talking about incidence rate when we are having patients seen every year, and what is the new patients that are seen, that is incidence rate. And these are all various rate measures when we are looking at cross-sectional survey and the prospective follow-ups. Can I have the next slide? Yeah, so when we are looking at the association between the exposure and the outcome, we are looking at effect size, that is the difference in outcome occurrence between two groups of individuals which differ with respect to an exposure. For example, if you are having, say, a smoker developing a lung cancer, so what is the association between the two is the effect size. Next. So that association between the two variables, that is the exposure to the disease, is called the strength of association. It is a very important measure for us to decide on, acting upon the exposure. So the frequencies of event occurrence being compared in two populations, that is one where the disease is there, one where there is no disease, and that is a case control kind of population or in a cohort study. So they are combined into a single summary measure so that we know whether the exposure has a positive association or a negative association. Say, for example, smokers will have a positive association to, a frequency of occurrence of lung cancer. But the same thing, if you are going to do a laser peripheral iridotomy to a narrow angle, it will reduce the, risk of developing angle closure. So that is how the positive and negative associations with respect to the effect size play out. Next. So we have all these various things on the left side, that is absolute differences, where you are having the difference between the two groups directly mentioned. And on the right side will be the ratios, which means you are getting the fraction of it, like relative measures. So these are the two ways in which it is expressed. When you are talking about rate ratio, risk ratio, and relative risk, they are all in a prospective setting. When it comes to odds ratio, we are talking about case control study or a retrospective cohort study, like what today's journal article was about. Next. So this is an example of a 2 by 2 table for you to understand what is odds ratio. So it is a case control odds ratio. We also call it as a relative odds. The odds ratio usually is computed in a case control study most often, and to look at the strength of association between an exposure and an outcome. It is an approximation of the relative risk of outcome. Why? Because in a prospective study, we will know what is the incidence of disease. Like every year, you're going to take how many number of cases are newly forming. And so we know the incidence rates. If you have the incident rates only, we can calculate the relative risk. If not, we only have how many you are talking from the disease and then you are going back to the exposure. So you can only know how many of these disease patients had the exposure previously. So if you actually look at the table here, if you are looking at the relative risk, you have to go to the top one. So how many of those who exposed had the disease? So it will be A divided by A plus B. So that is going to be your relative risk. So, but in case of odds ratio, what will you do is you are going to look at the disease and then see how many were exposed. So it should be A by A plus C. But in case of odds, you can only have A by C. That is the odds of exposure divided by the odds of no exposure in the disease population. That will become the odds of exposure among cases. So in this case, if a patient has lung cancer, how many of them were smoking divided by how many of them did not have the smoke exposure. So similarly, in the control population, you're going to look at how many of them were smoking divided by how many of them did not did not had an exposure to smoke. So that is your odds of exposure among controls. So when you have a ratio of these two, that is odds of exposure among cases divided by odds of exposure among controls, that becomes the odds ratio. Basically, it is the chance of having the exposure among cases divided by chance of having the exposure among the controls. So that way, if you actually look at it, finally it will come to A into D divided by B into C. This is the simple calculation that will come. And of course, if you want to get a p-value for this, you have to use a McNamara test and then get a p-value. Can I have the next? So this is actual a case example with the numbers in there. So here the odds of exposure among cases to get the lung cancer would be 800 by 200, that will be 4. And odds of exposure among controls will be 200 by 800. So obviously it is less. So 4 by 0.25 will be 16. So that will be the odds of getting lung cancer. I mean, the likelihood of having lung cancer when somebody is exposed to smoking in the past. So that is the wording you should be using, because these are retrospective studies. You cannot talk about causal effect. So causal effect can only be done in a prospective study. Of course, there is one exception. In some of the retrospective cohort studies, we can talk about the risk prediction, like what we have talked about in this EMR study, what we have seen, because we know these variables have a biological impact from previous studies, and then you are talking about the risk ratios. Now, you can also calculate a 95% confidence interval. So we can, extrapolate it to the population that we are dealing with, as you can see here. So there are some complex methods to do it using, Hansel ratio, and etc. So those things are beyond our discussion here. As I said, if you want to get a p-value for this table, you have to use a McNemar test. Can I have the next? Now, how to interpret these results? We know that there is an odds ratio number is given there. So how are we going to interpret it? So in a multivariate logistic regression, which we usually see, we are going to have it as the beta. So from there, like what you have seen in the tables which Dr. Geethu presented, you have like 0.2, 1.4, 1.2, 2.6. Say intraocular pressure has a, hypertension has a, or a family history has a 2.6 odds of having a risk for conversion, like that you are seeing there. So how are we going to interpret this? So if you have odds ratio of 1, that means there are no or little association. And if it is more than 2, it has a strong positive association. That means smoking has a 2, that is 200% likelihood of having lung cancer. Like that you have to think about. And OR less than 0.5 denotes a strong negative association. Depending upon the variable, we can talk about protective effect or causal effect. And odds ratio between 1 and 2 denotes a weak to moderate positive association. Same way, 1 to 0.5 will denote weak to moderate negative association. Next. Can I have the next? Yeah. So now you see that it is a crude odds ratio, and so because we have multiple confounding. So here smoking alone doesn't cause lung cancer. There are other variables, maybe age, maybe exposure to pollution, maybe a person is working in a factory concerning asbestos, so that can also cause lung cancer. So you have to look at multiple variables. That's when the multivariate logistic regression comes, that is mentioned here at 3. So that is how you do. So whenever we are dealing with odds ratio, we have to do confounding also. So a little bit I will touch upon. There will be another class for confounding as well. There is also stratification and standardization methods. I will just touch upon the stratification method to just give you an idea. Next. So I'll quickly go through this. Association between alcohol drinking and cataract is the question. Next. So this is the odds ratio that we are getting when we are putting it in a 2 by 2 table, 1.7. That is the crude odds ratio. Next. Next. So when we are having a confounding factor like next, smoking, which also causes cataract, keep going. Next. Continue. So when you're having the smoking versus cataract, the odds ratio comes as 5.31. Next. When you're looking at the interaction between alcohol and smoking, then it is 7.79. Next. So when you are going to adjust for the smoking, then the adjusted odds ratio for alcohol drinking versus cataract becomes 1.01, which is almost nil. Next. So when you're adjusting for the smoking, alcohol drinking does not have an effect on cataract formation. May or may not be true, but that is an example there. So how do you identify confounding? Causes of the disease be associated with exposure, not to be in the causal pathway of the exposure. I think there will be an elaborate talk in a forthcoming class, so I will not touch more upon this. Next. Next. I keep going next actually. Yes, so that is the stratified analysis. Next. So here is the whole example here. So the patient initially, when you are looking at the crude measure, it is 1.71. When you are stratifying according to smoking and non-smoking, it becomes 1.06 and 1. Next. Next. So next again. So when you are looking at it, so the smoker is approximately equal to the non-smoker, but it is not equal to the crude stratification. So the crude stratification becomes a falsehood. So you need to look at the confounding factors. Next. Next. So when you're looking at the multivariate regression, just now you saw in that study, there are lots of ORs presented. So the beta coefficient that is coming in the logistic regression table is the odds ratio. Next. So to summarize, odds ratio is an important effect size measure primarily used in case control studies and retrospective cohort studies in lieu of relative risk. Confounding and interaction need to be adjusted using study design or stratification or standardization or multiple regression methods. And it is a very important measure for us all to know about. Thank you. I think that ends my thing, and now we can have questions or comments.
Thank you so much, Dr. Bhaskar. It was a wonderful presentation and quite simplified. Actually, we should have done the presentation first so that we would have understood the journal one little better. But anyway, it's okay. So, so in our glaucoma, of course, this is one of the studies which we have discussed. In any other studies, that odds ratio would have been is there, and then do you want to say something about that so that people can understand a little bit more?
Yeah. So
In
see, when you are stratifying the intraocular pressure itself, like less than 18, less than 14, the odds ratio can also come in. Most of the time it is the case control studies where we are looking at stratified methods of intraocular pressure, like 14 to 18, what is the odds of association to glaucoma, like that. One of the examples I can think of offhand. And similarly, when we are looking at you know open and closed angle, usually it is a categorical variable, like yes or no, that is going to come into play for odds ratios. So open or closed angles, which has the higher risk of glaucoma, if you look at cross sectional studies, you can see that closed angles have higher risk of blindness, or higher likelihood of blindness. That is how it comes to. So apart from that, I think even the cup disc ratio more than 0.7 has a higher likelihood of developing glaucoma or association with glaucoma. So these are all some of the odds ratios that we can look at in the case control studies when we are looking at the clinical parameters. So I can't think offhand. Maybe Rajul or
the other
Sushma can.
panel members, please add your points.
Yeah, so I think, yeah, very lucid presentation, Dr. Bhaskaran, very simplified so that it was easy for us to understand. Well, odds ratio has always been, sort of a trick number where you can actually look at whether, these conditions coexist, and we have been using it for n number of things, whether it is glaucoma or general diseases. So only thing is that I would like to say is that when we are looking at the causative association or non-causal association, we have to be very careful about what we are taking as a risk factor and what we are taking as an outcome measure. Sometimes there may be a chance association. So there has to be a biological plausibility when we are talking about odds ratio for a given condition. So it has to fit in either in a causative factor or some relationship which has a biological association with a particular disease. Otherwise, we can have these numbers which can sort of, give us a false impression of association with a particular disease. A very common example, particularly Dr. Ravi Thomas used to give, was association of being overweight with people who do the morning walk. So if we start associating this kind of a things, then it becomes a problem. So what we need to understand is that the biological plausibility has to be kept in mind.
So another point which I would like to
It's
add
very
is
important.
odds ratio usually overestimates the risk association if you are going to extrapolate it. If you actually look at the example which our journal article today, it gave overestimation of conversion compared to the OHTS study, which was an RCT. So that is a classic example that it is overestimating it. And usually very rare diseases, it may be equal, because if you actually remember the 2 by 2 table, if on the left side all of them are very small, then it is almost similar to the relative risk. So if you are dealing with a rare disease, odds ratio may be equal to the actual risk of the disease from the exposure. Otherwise, I think you got to be very cautious in interpreting the causal association, even in the retrospective cohort studies that we talked about, but definitely not in the case control study. So you got to be very, very careful in talking about causal association. That is why we have to say it is likelihood or chance association, not risk factor. Many of the journal articles we see, they will talk about case control study, odds ratio, and then they talk about risk factor. I don't think it is a risk factor. It is just an association. We got to be very, very careful about that terminology as well.
Especially in odds and diabetes, it has always been a little bit of a controversy, because in this one, when we look at this particular study, the diabetes seems to be kind of showing that as it is patient having diabetes may have a chance of converting into glaucoma, from odds to glaucoma. So that is little tricky. So we got to understand retrospective, and then when we are trying to associate the causal factor, we got to be a bit more careful about. Rajul and Sharmila, do you have any?
No, I think Bhaskar has got very nicely. And Sushma already gave lots of input. Nicely covered.
Yeah.
I just wanted to just add, like
Yeah.
Dr. Bhaskar already showed that there are multiple risk factors. And so when you're putting into multiple risk factors, it's important to individually look at those risk associations and then again do a multiple regression to see if there is an individual risk factor which is again reflecting out in the multiple regression as well. This is, in fact, very important, because when you have more than one risk factor, and then when you're putting all of them together, it cancels out one effect on the other, and then you will get solely the ones which are significant in those becomes more important. Like alcohol and smoking, when you took alcohol separately, there was a different odds, and when smoking was taken, there was a different odds. But when all of this were included together, then alcohol as a risk was kind of nullified. So that's why multiple regression comes into play.
Yeah. So if there are no other comments, so thank you so much, everybody. Thank you, Dr. Bhaskar, for well-prepared talk and very practical and very simplified. I would say even a oversimplified talk for all of us to understand easily. And Dr. Geethu, you have just managed so well such a complicated one. Thank you so much to both of you. And of course, our panelists, thank you so much, Dr. Rajul, Sushma, and Sharmila, for being today for this journal meeting. So we'll meet up in the next journal meeting soon. And once again, on behalf of Glaucoma Society of India, as a president, I would like to welcome you all for this wonderful event of annual Glaucoma conference at Bhopal from September 12th to 14th. Looking forward to meet you, every one of you there. Thank you so much and good night.
Thank you very much.
Thank you,
Thanks
sir.
especially to Ms. Manjula for helping me out. Thank you.
Welcome, doctor.
Thank you.
Thank you, sir.